So is dapagliflozin a panacea for cardio-renal syndrome? And somebody added metabolic in this, but the original topic was cardio-renal. So we have these 5 types of cardio-renal syndrome. Type 1 is an acute cardiac dysfunction producing renal dysfunction. This we see often in our patients with acute decompensated heart failure. Once we dry them up with diuretics, they have a propensity to go into renal dysfunction. Type 2 is the chronic cardiac disease leading to renal dysfunction. This we see in our chronic heart failure patients. Type 3 is again an acute setting where you have an acute renal failure producing cardiac dysfunction. This sometimes we see classically in patients who have consumed NSAIDs, then they become breathless, pedal edema, and then you find that they have renal failure. And then they may actually develop arrhythmias also because of the acute renal failure. So that's how both of them might go together. Type 4 is again a chronic situation, chronic renal disease leading to cardiac disease. So we know that the 3 markers for cardiac disease are chronic renal failure, TIAs, and other places having vascular disease. And type 5 is a disease like diabetes producing both, which means both cardiac as well as renal disease. So basically, we are looking at dapagliflozin in all the chronic situations, which means whether it's type 2, type 4, or type 5. So these are the SGLT2 inhibitor usage in patients with cardiorenal syndromes. As I said, in type 2, type 4, and type 5, which are the chronic situations which have both kidney failure as well as heart failure or other cardiovascular disease going together. There's no doubt now that dapagliflozin is a very useful drug, and in fact, any SGLT2 is a useful drug. And type 1 and 3, which are acute situations, is of course controversial. So we'll come to those SGLT2 inhibitors in acute heart failure. There's a Robin Hood effect, which says that because of the shifting of metabolism from a glucose-based to a ketone-based metabolism, there is both protection of the kidney as well as the heart. There have been small studies in circulation heart failure with empagliflozin. 7 days after randomization, NT-proBNP was significantly lower, hemoconcentration was higher, but no change or increase in the creatinine. So basically, this is sort of which showed that in spite of diuresis, these patients did not deteriorate. This dictate acute decompensated heart failure trial with dapagliflozin. The results are still awaited. And then there's the EMPA response acute decompensated heart failure trial. The results are out, which basically shows that it is sort of neutral when you start the full dose of EMPA in the hospital in patients with acute decompensated heart failure. But what it does is it certainly reduces the rehospitalizations due to heart failure. And this has led to the common recommendation that you should start these drugs as soon as possible in your patients with heart failure. So basically in type 1, where you have acute heart failure plus some amount of renal failure, you can start this drug and keep watching the eGFR closely, because what happens is the eGFR decreases by around 5 ml in all patients that take SGLT2 inhibitors, and it gradually gets better within a week or 2. The other thing is the SGLT2 in the acute kidney injury set group of people, which means type 3. These people have acute kidney injury producing some amount of cardiac dysfunction or arrhythmias. This is one place where you would not like to use SGLT2 inhibitors with the current information that we have. So you can use them in the very mild cases, but otherwise you would not use them. And in fact, in contrast to the previous slide, as you can see, if the person is already on SGLT2 inhibitors, you would like to definitely continue them in type 1, but in type 3, you would discontinue the SGLT2 inhibitors in most situations, which means if the person is having acute renal failure and the person is already on SGLT2 inhibitors, even if there is a heart failure or a cardiac event, you would like to discontinue it for a short time. Coming to the other three cardiorenal syndrome settings, which means the chronic setting, whether the kidney is causing the heart problem or whether the heart problem is causing the kidney problem, or they're just associated with each other due to a common disease like diabetes. We have the three trials here with dapagliflozin, the DECLARE trial. Of course, we all know that. This had CKD type 2 patients in stage 2 in around 30%, but majority of the severe patients were excluded. Then we have DAPA heart failure patients. Only half of them were diabetic. And as you can see in this slide here on the right upper quadrant, you can see that almost 41%, which means nearly 40 to 50%, had eGFRs less than 60 ml. This also tells us how common cardiorenal syndrome is in patients with heart failure. And then, of course, we have the DAPA CKD, which is clearly a trial in patients with the chronic kidney disease whose GFR was between 25 to 75 ml. And a significant number of them, almost 70 to 80% of them, were at high risk for cardiovascular disease or had cardiovascular disease. So if you look at this trial, which is the most important latest trial, you can see that as usual, there is a significant decrease in the renal outcomes as well as the cardiovascular death. You can see the number needed to treat is only 19, which is a very significant decline. You can look at the p-value here also and the hazards ratio. So definitely a very useful drug to use in patients whose GFR is more than 30, even if they have heart problems. And then, of course, the kidney transplant or these are the renal events, again, significantly decreased. And then the cardiovascular death or hospitalization, again, significantly decreased by giving dapagliflozin. So all-cause mortality also decreased significantly by giving dapagliflozin. So the DAPA CKD study, very important study where you have CKD, a significant number of them having diabetes plus other risk factors, which would put them at a high risk for atherosclerotic cardiovascular disease. In this group, you can see that there is significant reduction in the kidney outcomes, in the heart outcomes, and all-cause mortality also. So if you look at one slide that compares all of these trials, and you can see here the mean GFR here is 85, which means there's a significant number of people whose GFR was between 60 to 85, almost half of them. Here, the mean GFR in the DAPA heart failure was 66. Like I said, almost 40% of these were having a eGFR of less than 40. And then in the DAPA CKD, of course, the mean GFR is 43 ml, and the cutoff was 30 ml. So as you can see here in this combination of kidney plus heart disease and diabetes in almost half of these two trials and in every patient here, you can see heart failure deaths as well as the kidney disease progression is significantly decreased. You can see the kidney progression is decreased up to around 50%. The heart failure deaths are significantly decreased by dapagliflozin in the DAPA heart failure and by empagliflozin in the non-heart failure group. Again, both of them seem to decrease the cardiovascular mortality better within the first 1 or 2 years after an index myocardial event. And in the DAPA CKD also, there's a significant decrease in the cardiac events also. So basically, if you look at it, you would use dapagliflozin or any other SGLT2 inhibitors, specifically DAPA, because there is evidence for it in the evidence in the basis of direct trials, randomized trials. You can see if it is more than 60 ml patients with heart problems, definitely you will use, including heart failure, of course. More than 30, definitely you would use with the current trial which is out. Less than 30, you would not use. A lower urinary tract, you would not use, but you would continue and you would use it later. Upper urinary tract, you would not use, you would discontinue if the person is already on it, but you can use later unless they have repeated infections. Genital infections also the same thing, but you can use after treating them well if they do not have a propensity for multiple infections. Of course, in severe recurrent genital infections or subcutaneous infections in that area, you would not use them at all. But here you can see the eGFR cutoffs. For EMPA is around 20, for DAPA is 25, and for canagliflozin is 30 ml. So thank you. So basically, this is a very simple talk on how useful these drugs are in the people who have combined heart and kidney problems. So except in the acute setting, the only controversial acute settings is patient with acute decompensated heart failure who might develop kidney failure. Here also, there is more and more evidence that you should start using dapagliflozin early during hospitalization. The other acute, the type 3, where you have acute kidney injury producing heart failure. Of course, this is a subset where you would not like to use dapagliflozin or any SGLT2 inhibitors in the acute setting, according to the current evidence. But the other cardiorenal syndromes, which are chronic and combine cardiac failure and renal failure, you would definitely use SGLT2 inhibitors and with a preference for dapagliflozin in view of the trials. Thank you.